Hello, everyone. I'm Dr. Carmen Puliafito, and I have here today with me Dr. Glenn Yu, who is professor of ophthalmology at the University of California, Davis, where he is also director of teleophthalmology. Glenn, welcome back to Retina Synthesis.
Thanks for having me, Carmen.
You were involved and have been involved in a innovative program on diabetic retinal screening in Northern California. Can you tell us a little bit about your experiences in teleretinology?
Yeah, so actually, it's interesting. This program started about, say now, probably 7 years ago now. I've always told people I'm actually a clinician scientist. I have a wet lab. I study mice. I have monkeys. So this is not necessarily in my wheelhouse, like, more kind of public health aspect of needing using telehealth for diabetic retinopathy screening. And it started really just with me being interested in the growing use of AI and telehealth and teleretinal screening. I got a small grant. I applied for it and got enough money to buy a single fundus camera. And I thought this would be a little side project of mine. And what started as a small side project ended up being a very large part of my life because it turned out that I don't just buy a camera and hope that it works. First, I had to work with all the internal medicine docs and get buy-in from them. You need to train the MAs, the technicians there to use the camera. You need to have a workflow to grade the images. You need EMR builds to create a workflow to how to report the results, templates. You need to have finances, like how does the billing work and who gets paid. And it actually taught me a lot about just general clinical operations and being involved with that. After that first camera, we found that we were able to increase the rates of diabetic retinopathy screening. It turns out that actually fewer than half of patients at our clinics, as well as in the United States, actually who are diabetic, get their eyes screened on an annual basis like they're supposed to. And so we found that we were able to bump that screening rate by about 15%, which when I first thought about it, I was just like, oh, I was hoping I would be able to bump it up to like 90%. But it actually took us from below national median to the top quartile nationally at that one camera, at that one clinic. And then I approached our hospital leadership. I gave them the results. I showed them what we were able to do. They agreed to expand the program to 7 sites, and then we started deploying cameras at different major clinics. You want to put these cameras usually in large clinics where there's a lot of flow. So especially if you start with the largest clinics where there's a lot of people to make sure the cameras are used. And then after a few years, we found that it was successful across these entire 7 sites, and we adopted the use of Luminetics Care, which was formerly IDX-DR, which was the first FDA-approved AI platform for DR screening. So about a couple of years ago now we went live and expanded to 14 sites, which covered our entire health system. And we even are now collaborating with other UCs to deploy teleretinal screening for diabetic eye care.
What kind of cameras do you use?
We started actually, it didn't matter at the beginning. We actually used an old like Nidec camera that was a 45 or 50 degree camera that was adequate for our use. We later switched to a Topcon NW400, which is a little bit more automated. So the person using it doesn't have to be a photographer. Essentially, it's very user friendly. We've even had undergrads learn how to do this. You just see the picture of the patient's eye, and it almost automatically finds the eye and focuses and does the capturing. And then for a while, we also moved to the Optos Primary, which is a primary care version of the Optos platform that's much lower cost, which gave us the full ultra wide 200-degree point of view, which was nice. It had much lower rates of ungradable because it gets through smaller pupils. It was more likely to get through cataracts as well. But we ultimately decided to move toward an AI-based screening program, and all of the Luminetics Care platform relies on the Topcon NW400. So we went back to that camera platform.
So how does the interpretation work?
So previously, well, when it first started, it was me solo. I would just get the images. There were only a handful of them, and I created a template and I reported the results. Over time, I started involving the retina fellows. So we had like a team. We developed a grading protocol, so we were all on the same page. But when we started moving toward the 7 sites, I decided to offload that from ophthalmology to optometry. So we have a number of very talented and very experienced optometrists who essentially we covered a small proportion of their salary to grade a lot of these retinal images. And that essentially is to this day is how it's done, because even though we've moved to the AI platform, we actually incorporate more of a hybrid system, because a number of those images, either the AI will say is ungradable because of poor image quality, but humans can still interpret it enough to make a clinical judgment. So we still have a overreader, which is an optometrist on our team. Or we also decided that a lot of the positives, because the AI platform doesn't tell you how severe the retinopathy is. It just says whether there is more than mild or just mild or below. So anyone with no retinopathy or mild retinopathy is considered negative, and those are just screened on an annual basis, whereas those with moderate or higher levels of diabetic retinopathy are screened, are referred for in-person evaluation. And so the optometrists, for all positives, they will also regrade those images to make sure that there are no false positives, like a lot of younger patients who have that sheen on their retina may be misinterpreted as retinopathy. Or if it was graded, they will also assess severity to help us assess the urgency of the referral. For some practices, I know like Stanford and Hopkins both and Wilmer both have the platform implemented, and they don't seem to have an access issue, so they just refer anyone that has a positive screen. Whereas for us, if we detect disease, the next available appointment may not be available until like 3 months out. So we need to stratify the urgency, so those who are more urgent get seen more sooner.
So most of the positive images are reviewed by a human?
For our platform, yes. That's how we're doing it currently. It continues to evolve. We're really assessing the quality of the screens, how many false positives, how many false negatives we have, and we're also working with the vendor to see when they may get a more granular stratification, so that we don't have to overread so many images.
So where does the positive ones that are deemed to be clinically significant, who sees them in person, optometry or ophthalmology?
So it depends. So we right now stratify, once they are considered positive, we further stratify them to urgent or non-urgent. So we consider vision threatening, so that's PDR, proliferative diabetic retinopathy, or any diabetic macular edema, to be urgent. So those are going to be seen within a month, and those usually will go straight to retina. If it's within 3 months, like moderate or moderate severe, or somewhere in that category where it's not considered urgent, they will be seen within 3 months, and that's usually sent to optometry. Optometry then makes a determination of whether they need to be evaluated by retina, comprehensive ophthalmology, or others.
What percentage of these eyes ultimately have OCT in the positive group?
Ultimately, in positive group, it's actually a very small number. It depends on whether they actually come to the retina service. Most patients who actually have vision affecting, so when you're talking about OCT, I presume you're thinking about DME and diabetic macular edema. The thing is that most people who have diabetic macular edema will have some kind of visual complaint. And I think that the screening program in general are looking at asymptomatic people. And of those asymptomatic people, it's actually a very small percentage. If you look at the patients who actually have like DME or PDR in the screen, it's probably in the single digit, if not below 5%. So we're capturing a small population of that. but we are screening like 1,000 to 2,000 patients a year at least. So we still are capturing a good number of patients.
So, do you think advances in imaging quality and AI will advance this field?
I think it's definitely going to advance the field. And I think it's very important because right now it's a one trick pony. It tells you whether there's diabetic retinopathy or no diabetic retinopathy. Some of the newer platforms will stratify to what they call more than mild or vision threatening, which is essentially what we're doing just with an overread system. But I think that there's a lot of, when we have human ophthalmologists or human optometrists grading these images, we can see things like glaucoma suspect, possible cataracts, maybe AMD. So all these other pathologies are not being captured by the AI platform. So I think that being able to expand to other eye diseases besides just diabetic retinopathy will be critical. The second aspect is there's this growing field of what we call oculomics, which is the concept of using the eye as a window to more systemic diseases like cardiovascular risk, thyroid disease, or hypertension. And all of these things could be detected with enough training of AI based platforms. And I think that will be the future, that we will have some platform that people can get screened for multiple systemic and ocular conditions with these fundus photographs. And it's just a matter of training better models that become FDA approved.
What about whole eye OCT, such as developed by Alex Walsh?
Yeah, so I'm seeing a lot of work. Even Heidelberg has this Anterion system, which is a swept source based ultra wide OCT, and then you just combine anterior segment ultra wide swept source with posterior segment ultra wide swept source, and then you ultimately can get, if you put it all together, you get a perfect circle, and you can get the whole eye. I think that there's promise. I think there's significant limitations. So when you look at OCT instrument design, the optics for doing anterior segment OCT and posterior segment OCT is different. So the whole eye OCTs are really a merge of the two technology, but it's not like one single scan just does it. It's a hybrid of two different scans. And because of that, there's a lot of potential processing errors. There's how those images emerge. A lot of the pictures that you see are manually put together, so it can be quite labor intensive. Now, obviously, with AI, a lot of that could be probably automated, like aligning and matching and montaging images. But I think the technology is still limited. I think it's the question is how much does it add, right? Like in a lot of things the technology can always improve, and you can take bigger pictures, you can do wider fields, more details, but the question is just how much incremental sensitivity and specificity do you have to capturing more diseases? And I think right now it's hard because right now I think we have the most volume of standard color fundus photographs from these screening programs. So I think in terms of data used to train AI algorithms, we have more of these than like the more fancier, newer OCT or other imaging technologies. So I think it will continue to develop over time, but for now, I think we're still relying on relatively old technology of just color fundus photographs.
Is there a lot of research in AI looking at interpretation of images?
I mean, certainly, I think we have definitely already a lot of robust research on using AI to interpret retinal images for detection of diabetic retinopathy, detection of macular degeneration, detection of cardiovascular diseases, and more importantly, prediction. And I think that that's going to be the most exciting things. It's not, there are algorithms that will predict your risk of cardiovascular mortality in the next 5 years. And that's probably more critical, I think, is not just screening for things that are now, but things that may happen that we can do something about, especially in terms of preventative care.
Uh, Administration and finance. Who manages this program over these? You have 14 sites, did you say?
Correct. Yeah. So right now, I'm the medical director for the teleophthalmology program at the UC Davis Health System. Most places they're run either by internal medicine or as a partnership between internal medicine and ophthalmology. The finances are complex. And in fact, I think right now the barrier to widespread implementation of teleretinal screening is higher in terms of the logistics and finances. Like all things in healthcare, it's one thing to develop fancy technology like gene therapy. It's another thing to get it into the clinical setting because someone needs to get paid, and you need to have a business model. The biggest challenge historically with teleretinal screening is that it doesn't pay very much. And also who gets paid. So we started out with this back in 2011, I believe. CMS released these specific CPT codes for billing teleophthalmology. Lower codes were paying like $10 an image, whereas something like fundus photography, um, which pays about $50 to $60, was slowly increasing over the past decade. So a lot of people were actually just billing it as fundus photography, even though it's not it's a teleretinal code, even though it's teleophthalmology screening. So I think that that's one major challenge. What has helped is in recent years, we've worked with the RUC advisor and the AAO to improve the reimbursement or the definitions of what these codes are. There's now a specific code called 922229 for AI-based teleretinal screening, which actually pays a little higher than human screening. If there's any human involved, those codes, which is 9228, usually is split billed between the facility fee goes to the place where the camera is deployed, and the professional fee goes to the interpreting doctor, which for us is optometry. So at least both sides gets covered in that sense. But I think the challenge will be the technology, the logistics of how to roll these programs out and making sure that it's at least budget neutral, if not budget positive, for large health systems to adopt.
Who paid for the equipment and the software?
So when we first started, it was an investment. As I mentioned, the first camera was from a grant. When we decided to start expanding it based on just operations, we actually published a paper looking at cost analysis and showed that we make almost no money from the screening program. If anything, we lost a little bit of money. But what we found was that if you look deeper into incentive-based programs, as well as quality metrics, which improved certain quality-based incentive payments, we actually were making a lot more money off of those, as well as actually downstream referrals when we refer them back into our eye center. I think one patient actually had something subtle. It was like one little spot we thought was a hemorrhage, and it came in. It turned out it was a macular hole. I went back to look at the fundus photograph. It didn't really show enough evidence to suggest it was a macular hole. But that person came in and we did a surgery. So if you look at all those downstream revenue from those referrals, surgeries, new patient visits, we definitely more than make up for the cost of the camera. And so we bought the cameras. Now that was when we bought cameras to have human screening. Now when we move to AI, a lot of companies, including Luminetics Core, are using more of a leasing program where you don't actually have to pay for the equipment up front. You essentially pay per month and also per click. And essentially the advantage of that is that when you buy a lot of equipment, it's a lot of upfront costs. And then if there's always the evolution in technology, it's like buying an electric car. There's so much change in the quality of the technology that there's rapid depreciation. Whereas here, if there's newer technology or newer software, then the company is obligated to update that as part of the contract. So I think that it's probably the way most of these AI programs have to go, rather than having the health systems like put an initial bill for the camera costs. But I think every contract is unique, every company is unique, so everyone negotiates differently depending on their specific situation.
So if you were advising a large retina group that listens to this podcast and is interested in going forward, where do they start?
I mean, the main thing is, diabetic retinopathy screening. So we're specifically talking about screening. There's a whole other world of teleophthalmology for actual ophthalmologists or retina specialists in practice. And that I'm not an expert on. But so most of these programs are really starting with major health systems that are like mostly by internal medicine or family medicine. So the main question I think to your listeners are, if you're a retina specialist and you are affiliated with a hospital system and you want a potential revenue stream or referral stream of patients who are referred for these eye conditions, I would probably talk to health system leadership from those hospital systems or whatever practices, general medicine practices that may be referring patients to you. The main question is to work out what is the unmet need? Like, what is the current rates of people getting screened? How many patients are being who are screened? Where are they getting referred? If there is a significant unmet need, these are people who are, let's say, diabetics who are not getting screened on a regular basis. You need to convince the leadership. You have to do calculations of how much money it will make them if they improve those metrics, because usually everybody has a different payer mix and different participation in incentive-based payments. But for use, especially for California, the state actually pays us significant amounts of money for hitting certain quality metrics. Even some FQHCs in that have primarily a Medicaid population, they have metrics to hit. So I think that those evaluations have to be done. Once you know whether that there is a certain amount of money that's left on the table because you're not screening enough, then you have to work out some kind of arrangement so that either the hospital system manages the whole thing and use AI and just refer you all the patients, or you have, like us, some kind of involvement where we participate in that screening program. The only key is to make sure you work with compliance and legal teams to make sure you don't violate Stark laws of like self-referrals, and figure out a system. But I would say that would be the first start. And then obviously discussing with vendors. They're a good wealth of information on everything from billing, logistics, deployment, EHR integration, all that stuff. But it's definitely a lot more complicated than I thought I was initially getting into.
So start with the AI vendors, maybe?
I would say start with the AI vendors, start with your hospital leadership to gauge interest, right? And then yeah, talk to the AI vendors, even some of the non-AI fundus camera vendors. There are platforms out there where you don't need to do any work or use AI. They will set up the cameras, and they have an entire team of providers that will grade images and send those send the results back to you. So those are other options as well.
So how big is the unmet need? In the real world, what percent of patients that need to be screened are being screened?
In the real world, it's less than 50%. It's somewhere in the high 40s. I think it varies from like 46 to 49, depending on what year and what data source I'm looking at. And if you look at most health systems, like when we compared UCLA, UCSF, UCSD, and us, some campuses like UCLA was really low. It was down in like the 20 or 30% are actually getting screened. Now, obviously, the population, the geography, like we're actually have more access to rural and suburban sites, whereas UCLA is mostly urban. But we're also, like San Diego, are more centralized. Like we have probably 10 to 20 main sites that covers like 90% of our health system. Whereas for UCLA, they're so widely distributed with a lot of smaller clinics everywhere that it's harder to implement. With you can't. It's very hard to deploy like 100 cameras, right? So you would have to have some system for people to go to one single place. So that all those numbers are very different for everybody. But I think the unmet need is definitely quite high, and we just have what we have recorded. We're basing it on what we've annotated as screened, but we don't know how many of these patients actually got screened, or whether documentation using these EHR platforms are always non-accurate. There are also patients who might be getting screened but not getting captured. Like if they just went to an optometrist and got their eyes dilated, we may not have captured that if they are not familiar with that. So we're doing a lot of research right now, looking at who's getting screened, who's not getting screened, number one. We created these like QIMA, like quality improvement medical assistants that will go through thousands of patients at a time and review charts and then call patients up to screen them. And then we're also working on the back end of looking at patients who were screened who don't show up for their in-person follow-up. That's another major unmet need, because it turns out that also fewer than half of those actually, if they got screened, they got a flag. It was retinopathy, and they didn't show up they never set up an appointment. And we found out that there was actually loss at various levels. Some of them, the doctor didn't make the referral, even though they got the positive results. Some of them, they got the referral, but they couldn't reach the patient. Some of the patient made an appointment and didn't show up. So we were hoping there was like one care gap. We just need to close that gap. But it turns out there were just a lot of mini gaps all along the way. And so we actually have doing some work with implementation scientists and mixed methods qualitative research, where we actually do surveys to call patients up and figure out where the barriers are. Most of them seem to complain that they just didn't get the results, or they didn't know how to interpret the results to understand, to really fully understand that they need to come in. Many of them are not English speaking, so maybe developing materials in other languages, or having more consistent, clear workflow for results reporting, so that the patient knows, hey, this is important. I need to come in and make an appointment. That type of education needs to happen as well.
So imaging and AI are fantastic, but they can't compensate with the realities of humankind.
That's correct. And I think it's improving the technology, but we also need a significant amount of work in just deployment and integration into our healthcare systems.
Well, thank you very much, Glenn, for this very enlightening discussion.
Yeah, no, thanks for having me.